And the title of my talk was raised by this article, which some of you may have seen in the New York Times in February upon the publication of the voice results in the NEJM. And unfortunately, in this article, African women who participate in trials were characterized as liars and duplicitous, and money was seen as their main motivation for participating in trials. And this article generated several waves just prior to the CROI conference in 2014. So I wanted to explore whether money matters and how social context shapes HIV risk and uptake of biomedical prevention, particularly among young women. And then ask the question, if money does matter, can cash prevent the spread of HIV? So since 2010, we've seen an amazing advance in science in terms of antiretroviral-based prevention, particularly with respect to PrEP. 6 trials in diverse geographic populations across the world have shown that PrEP works when taken. And in particular, in those that take it, high levels of effectiveness were observed. Most recently presented at CROI were the Efficacy and the PROUD trial, where reductions of HIV incidence of 86% were observed. But 2 trials, both of them in women, have demonstrated a lack of efficacy of PrEP. And in both of these trials, women had detectable drug levels less than 30%. So the question was raised, why is it that we're seeing low levels of PrEP efficacy amongst women? One explanation has to do with pharmacokinetics, pharmacodynamics. We know that drug concentrations at the exposure site are much lower in the vaginal compared to the rectal tissue, particularly with oral concentrations of drug. And in these populations, as you've seen in sub-Saharan Africa, there may be other inflammatory factors such as STIs or genital inflammation, which may modulate the effects of PrEP in the genital tract. But the bigger question is, why are we seeing low adherence, and why are levels as low as less than 30% of women actually taking their drug on a regular basis? Is it because they have a low perception of their HIV risk? Was it a lack of motivation when they were in a placebo-controlled trial and were uncertain of the efficacy of this product? Do they have a lack of self-efficacy and are unable to negotiate safe sex, but also use of products within their daily lives? Is it just the inability to take a pill, forgetting every day? Or was it associated with HIV treatment stigma and people's reluctance to show that they are taking pills? Or simply a lack of interest in HIV prevention? Or perhaps just the competing priorities in women's busy lives, particularly in the southern tip of the continent? So these were some of the questions that those 2 trials generated. And it was with some disappointment in February 2015, that we presented the results of the FACTS trial, which showed a similar result, no effect for tenofovir gel in preventing HIV acquisition. And what I want to do is spend a little bit of time exploring the results of the FACTS trial in a little bit more detail and what we've come to understand about adherence and how it is shaped by the context in which women live. So the primary objective of FACTS 001 was to evaluate the safety and effectiveness of pericoital tenofovir 1% gel. And the purpose of this trial was to confirm the results of CAPRISA, which was a much smaller trial, as a part of the pathway to licensure. In this trial, we evaluated a pericoital regimen, BAT24, that means applying a gel 1 dose up to 12 hours before sex and 1 dose 12 hours after sex, with no more than 2 doses in 24 hours. This was unlike VOICE, which used a daily dosing regimen. The study was designed as a phase 3 randomized controlled trial. Women who were 18 to 30 years were enrolled. They were HIV negative, sexually active, not pregnant, and were willing and able to use contraception and condoms. They had no contraindications to tenofovir use, and in this trial they were enrolled irrespective of their HSV2 status, but also their hepatitis B or breastfeeding status. And they were randomized to either 1% tenofovir gel or placebo, followed up monthly for up to 27 months. At each of these visits, they were tested for HIV, blood was collected for safety assessments, and at quarterly visits, cervicovaginal secretions were collected, and they were counseled and had product resupplied at each of the visits. All of this was done in the context of a comprehensive package of HIV prevention, and the primary endpoint of the FACTS trial was HIV infection. So we had learned a lot from Voice and FremPrep, and we certainly built on those experiences when we implemented a series of adherence support strategies. Initially, we focused very much on participant-centered counseling. We developed supportive materials, models, we had demo gels, and sites developed innovative BAT24 clocks to help people understand the notion of BAT24. We used a motivational interviewing approach, which was used in CAPRISA, and includes an adherence prescription where women identify their barriers to gel use and make plans to address those barriers. And in the trial, we introduced simple checklists and calculators so that we could identify participants who had lower than expected adherence and provide them with additional support. In addition, we learned that the social context was very important. In a young population, peer influence is important, and so we developed motivational messages that were delivered to individuals via SMS, but we also developed these sorts of posters that were pertinent to the stage of the trial and to, for example, the holidays, creating an image of using the gel in a very positive, young environment, an aspirational environment. We also developed a film that was shown within clinics, which created narratives around gel use amongst women. And we had mean adherence monitors which were displayed toward the end of the trial, showing women mean adherence and encouraging them by showing that women were reporting using the gel. Another innovation were FACTS clubs, which were based on antiretroviral treatment support groups, and these were very important in women's participation in the trial, as we discovered. So we screened just under 4,000 women and enrolled just over 2,000 women who were followed up until we had accumulated the target number of endpoints. We accumulated just over 3,000 women years. 90% of women attended their exit visit, and we only had 25 women who were not included in the primary analysis because we had no HIV results, either because they were positive at enrollment or because they didn't return for a subsequent visit. So these are the baseline characteristics of this population, and I want to draw your attention to some specific characteristics. You'll notice that this is a very young population. In fact, this is one of the youngest PrEP prevention cohorts to date. Nearly 3/4 of them are under the age of 25. So technically, this is a an old adolescent population. The majority of them were single. They lived with their parents or siblings. About half of them had attended high school. Very few of them were employed. And the majority of them lived in impoverished circumstances. This is the main result, a very disappointing result. We saw 61 infections in the tenofovir arm, 60 infections in the placebo arm, giving us an incidence of 4% in both arms and an incidence rate ratio of 1 with a confidence interval of 0.7 through to 1.4. So you couldn't get a more definitive result than that. What have we come to understand as the meaning of the results of the FACTS trial? So the first question is, was it adherence? Did women not use the gel and therefore we didn't see a result? Well, this is a summary of the adherence calculation that we did on a monthly basis. I want to remind you that this is not a daily product, it was a pericoital product, so we were required to calculate the proportion of sex acts that were covered by gel. And what you can see is this, in this graph, is that between 50 and 60% of sex acts per month were covered with gel. And that was the same in both arms. But when we looked at those people who were in the highest adherence category, so greater than 80%, which was associated in CAPRISA with higher levels of product efficacy, we saw that a very small proportion of people were able to use the gel in 8 out of 10 sex acts. In those people who did have detectable tenofovir reported in the last 10 days, we were able to demonstrate that there was some protection. Importantly, only 13% of women never had any drug detected, so 87% had drug detected at some of their visits. But again, we saw that only 22% had drug detected at every visit. So what were the factors that predicted who would adhere and who wouldn't? Using, again, the semi-objective measures, we looked at the proportion of what factors were associated with the proportion of women who used gel in more than 7 out of 10 sex acts. And you may agree with me that this is a fairly high bar. What we saw is that women who were married were more likely to use gel. Women who had primary education were also more likely to use gel consistently, while women who lived with their parents and siblings were less likely to use gel. There were no significant associations between high mean adherence and risk perception, partner characteristics, sexual behavior at baseline, and we're doing ongoing analyses to understand the time-varying associations with adherence. But importantly, as with other trials, being single, living with parents, were also risk factors for HIV incidence, and as in other trials, we see that they're associated with low adherence. Importantly, in this trial, what we observed was that mean adherence to gel use was also associated with a lower HIV incidence overall, irrespective of trial arm. And this suggests to us that women who were able to adhere also had a lower HIV risk overall. So I want to now explore in a little bit more detail through the qualitative data what we have come to understand about what influenced adherence in this trial. We conducted in-depth interviews in 140 women drawn across the 9 sites, and we explored a range of themes that had percolated through previous trials, including women's risk perception, their perceptions of gel efficacy, the feasibility and acceptability of gel or the dosing strategy, and their honesty in reporting. The sample of women was similar in most respects to the overall trial cohort, with one noteworthy exception. There was much lower adherence in the overall cohort much lower adherence in this population than in the overall cohort, with only 10% of women achieving more than 80% adherence, whereas we saw about 13% or 22% achieving high adherence in the overall trial. So when women were asked, did they perceive their risk for HIV, this quote illustrates that when a woman reported, I was not using a condom every day, and it was a risk because I don't know what he does when he's not with me. Women regarded their risk of HIV as being acquired through the actions of others. Those who recognized that they were in stable partnerships recognized or acknowledged that those partnerships lacked in trust and commitment, and they therefore couldn't account for their partner's behaviors. But similarly, those women who were in stable partnerships also expressed suspicions of fidelity. And in particular, in this all South African cohort, rape and the narrative of gender-based violence came through the interviews, with women expressing their concerns about their vulnerability to rape and HIV infection through sexual violence. Importantly, women liked the gel. They associated with positive attributes like cleansing, sexual pleasure, intimacy, and lubrication, as these quotes illustrate. And while there were some complaints about wetness and leakage, women were able to overcome these difficulties early on in the trial by talking either to other women in the facts clubs or through their monthly visits and discussions with counselors. So most said that it was actually relatively easy to comprehend BAT24 after a time. As with every new behavior, it takes a while to create habits and to kind of figure out how to make things work, as this quote illustrates. But knowledge and acceptability didn't necessarily translate into behavior. And these 2 quotes highlight the importance, particularly in this population, of inserting the second gel. Women understood the meaning of the first gel. It was preventive, but the second gel was often inconvenient, either because of concerns about inserting gel in front of partners, or just because people didn't see the reason for it. And importantly, everyday life and relationships made gel use more complex. So it was easy to insert the first gel because I would still be at home, but it was difficult to insert the second gel if you didn't tell your partner about being in the trial. And it was easy to insert the first gel because I inserted it when I was at work or at home, but then when I go to him for the second gel, it was difficult to because I have to wake up in the morning or wake up at night, so I didn't like to do that because I'm sleeping. Importantly, in the facts trial, women reflected on their honesty in reporting. In the interviews, we explored whether women were telling the truth. And what we heard is that initially women were uncomfortable about telling trial staff about their adherence. But as the trial progressed and they became familiar with staff and they realized that they weren't going to be treated with judgmental attitudes, they told the truth. There were consistent reports throughout the in-depth interviews of women recognizing the value of actually having frank discussions about the barriers that they experience to adherence. So what are the implications of the FACTS trial? Well, we saw that pericoital vaginal tenofovir gel was safe, but it wasn't effective in preventing HIV in this population, and it is unlikely that for this population it will be licensed for use. We saw that women did use the product. This is confirmed on more than one measure, but that consistent use was not common, and that's what we need for protection. In women who did have consistent use and had recent sexual activity reported, there was some evidence of a protective effect, but this is in a subgroup and therefore difficult to generalize. But unfortunately, the majority of participants were not able to achieve the sufficiently high levels of gel coverage that were required for protection. And this is despite high levels of acceptability, high levels of support. Even in this situation, pericoital use was challenging to incorporate into the everyday life of women. So young women urgently need HIV prevention methods that may be easier to integrate into their lives. And Nyeratso has certainly highlighted what some of those may be. What we need are HIV prevention options for women that can work for them. Ongoing work may define these new products that will respond to patient preferences and provide a choice of method. And we also need to acknowledge that trials may be different from real-world settings. We do have a product that works in the form of oral PrEP, and we need to begin to understand how to deliver that product to populations at highest risk. In the HPTN 067 trial or the ADAPT trial, what we have is data from women in Cape Town that show that in an open label study that compared daily dosing with non-daily dosing regimens, women who used daily dosing, 93% of them had drug detected at week 10 and 79% at week 30. So it is possible to achieve high levels of adherence in these populations of young women. But we've also learned that the social context of trial participants' lives really shapes both their risk as well as their use of products. And is there evidence for interventions that could address these upstream contextual factors? So now I want to shift gear a little bit and talk to you a little bit about structural interventions that may also benefit HIV, young women in terms of preventing HIV. Does money matter if we think of that New York Times article? And can cash prevent the spread of HIV? Well, interestingly, there's a wealth of evidence that is emerging that cash transfers can improve people's education, health, and lifelong earnings, and have been adopted for decades, particularly in Latin America. And what we see is that cash transfers, particularly targeted to the poor, have shown improved use of health services, nutritional status, health outcomes, and uptake of preventive services. So there's been an interest in the potential role of cash transfers that could be used to reduce HIV risk, either through a sort of more long-term social protection measure, which is to address the underlying poverty and inequality that young women live through that makes them vulnerable, or the behavioral economics approach, which sees that behaviors can be modified perhaps by providing nudges, and so direct incentives could change behavior. Either way, we think that cash might change either income or consumption choices, that this may alter people's ability to negotiate sex, and that this may also address contextual factors like violence or their choice of partners, and so their need to exchange sex for resources may be modified. So what is the evidence for cash transfers for HIV prevention? Well, I'm going to share with you 3 trials that have been conducted in sub-Saharan Africa that show promise for cash transfers. The first was a conditional lottery incentive for the prevention of STIs that was conducted in Tanzania. And there they saw significant reductions in STIs of up to 24% from lottery incentives where the value of the incentive was $60. And the effects were the same for men and women. Perhaps the most striking data comes from the Zomba trial, which was a trial of conditional and unconditional cash transfers in Malawi. There they saw a 60% lower prevalence of HIV for schoolgirls who received the cash transfers, which were only $15, and that there was no difference on whether that cash was conditioned on school attendance or unconditioned. Importantly, there seems to have been a direct income effect in this trial, where young women who received the grant were able to choose age-congruent partners, relying on older partners, and so the cash was used to substitute for transactional sex. Importantly, in this trial, we also saw other significant health and education outcomes, including reductions in teen pregnancy, higher rates of school continuation, lower rates of HSV2, so benefits beyond HIV for cash transfers. More recently, there has been another trial of, again, of lottery incentives in Lesotho, where they saw and this trial was particularly in young people, that saw significant reductions in STIs and HIV from between 20 to 30%, who were offered 4 monthly lottery incentives to the value of either $50 or $100 every 4 months to stay STI and HIV free, and larger effects were seen in women. So, should cash transfers be part of a combination HIV prevention approach? And there are a number of questions that we might want to consider. The first is the evidence robust enough? While these were randomized controlled trials, there are some limitations to those that I've just presented. Either STIs were the outcome or HIV prevalence was the outcome. And we expect that we will have more data coming out in the next year from either Caprisa 007, which was a trial in KZN, which evaluated a cash transfer approach, or HPTN 068, which is a trial of conditional cash transfers to young women in Mpumalanga. There's also increasing interest in the use of cash transfers to support adherence, both to HIV treatment, but also some interest now in using incentives for PrEP. But interestingly, at CROI, the TLC plus HPTN study didn't show any overall effects of incentives when looking at linkage to care and viral suppression, so there's more work needed around direct incentives to understand their mechanism. Nevertheless, they're an important intervention to explore. But more importantly, if we begin to believe this evidence, the critical questions are, how can this approach be included in an HIV prevention strategy? Are these interventions scalable? Now, interestingly, we've seen a rapid expansion of social protection, particularly in sub-Saharan Africa, with social protection programs expanding from 21 in 2009 through to 37 in 2013. So this is something that is happening anyway. Is it affordable? Well, currently, for most countries, they spend less than 2% of their GDP on social protection programs. South Africa is a notable exception. South Africa spends up to 18% of its GDP on social protection and covers young women through a range of grants. And so South Africa may not have the ability to expand, but already has a fairly comprehensive program. But there are many other countries that do have, in the region, that do have potential to expand. And is the effect of these cash transfers durable? Well, we don't really know the answer to that question, and we are going to have to look at sustained follow-up of participants to see how long these interventions may provide protection. But if we're convinced that money matters, what can we do with this evidence? Should we just continue with expansion of social protection programs, and now we know that HIV may be an additional benefit, or do we, as we adopt the fast-track approach and think about strategies to optimize prevention, particularly for young women who have limited HIV prevention options, should we think about targeted assistance to young women in combination with PrEP or alone? Importantly, the World Bank has highlighted in a talk that David Wilson gave at CROI that sources of funding, in fact, do exist, and we just need to leverage them more effectively. As we've said, there are social protection programs that are already in operation that are based on revenue generated through taxes. But there are also specific programs. The World Bank, 50% of its portfolio is focused on incentives for health, largely around maternal and child health. But these could potentially be leveraged for young women. And then there are HIV-specific incentives that could be leveraged through the Global Fund or PEPFAR. So in conclusion, I think that money does matter. Young women have an unmet need for HIV prevention, and many of the forces that put them at greatest risk do have to do with poverty and income inequality. PrEP is going to be a critical component of a combination HIV prevention approach. But we are potentially going to need to do more for young women to support their adherence, particularly when we think of the social context in which they live. So in addition to the other health, education, and livelihood benefits CASH has to offer, we have the potential now to reduce HIV infection in young women. Direct incentives for adherence require more investigation, and there are several demonstration projects that are considering the inclusion of incentives for PrEP adherence in young women. But ultimately, combination approaches are going to be needed if we're to achieve the significant population-level reductions in HIV incidence that are required to end the epidemic, particularly in the context of the fast track. So with that, I'd like to acknowledge my colleagues in the FACTS study group, as well as colleagues at WITS RHI, the STRIVE consortium, which is committed to exploring the structural factors that drive HIV and interventions to alleviate them, and the Rethinking HIV Prevention group in young women, which has also been instrumental in some of these thoughts. Thank you very much.